Okay, so now we'll move on to Dr. Amit Porwal. He'll talk to us on dealing with anterior capsule of mature cataracts, hard brown cataracts, and hypermature cataracts.
Thank you, Dr. Meenu. And for the audience, most of the tips will be the same, most of the procedures will be the same for the rexes, what everybody's been talking about. The cataracts also are same. They'll be hard, mature, intumescent, soft. But every surgeon has one tip, which if you can pick it up and take back, it will be very advantageous to you all. So no financial disclosures. So we all know this mature intumescent, hard brown and hypermature cataracts. Most of them are swollen, congested. There's hydration of the lens matter. There's increase in intraanterior pressure. These lenses are very bulky. These cataracts are bulky. They're usually associated with mid-dilated pupil and pseudo exfoliation. So what are the problems which we face during performing capsular rexes? The anterior capsule is, when we look at the anterior capsule, there's difficult visualization. They're calcified, they're stretched. There can be pseudo exfoliation material, there will be loose zonules. There can be a peripheral split, which after the first puncture leading to the Argentine flag sign. So it's already been discussed by my previous speaker. What is described in the literature is mini rexes, snail pattern rexes was very nicely demonstrated. Sometimes when you're doing the rexes, your rexes gets extended, and what Dr. Meenu was telling, snap it, pull it towards the center, and you will end up in getting a heart-shaped rexes. And in this intumescent cataract, we can also do a puncho rexes. But what I'm going to recommend is and what I do and what I've published. So this is a mature intumescent. This is a mature intumescent cataract. Staining of the capsule is very, very important. Why staining is important? Because these capsules are elastic. The moment tryptophan blue dye touches this capsule becomes rigid a bit. So when you have a rigid capsule, you have a better control. Now you see, I am piercing the center of the anterior capsule with a 24 gauge needle, which is mounted on a 2cc syringe. You have to be gentle, steady. Only the bevel of the needle should be pierced inside. You should not have any tremors, and you try to aspirate. The moment I aspirated, you saw the bulge, the convex became concave. Now put a cohesive viscoelastic. Again, you should not overfill the anterior chamber. It should be just adequately filled. Start with the small rexes. Whenever you do this intumescent cataracts, always start with the small rexes, and then you can refashion it. Now I'm doing this a snail pattern. First started with the small rexes, then I thought I have a better control, I can do a snail pattern rexes. So you have to decide on table which technique you are going to adopt it. Always make sure that the flap is flat. Even if you have a decentered rexes, in this type of cataracts, don't bother. You know that what will happen. You take out the cataract, inject the IOL, now you saw the rexes was decentered. So what I'm going to do is, with the micro one, I gave a tangential cut, and then I'm refashioning the rexes. This you can do with the help of a cohesive visco, but now what I found out was, with the hydration cannula in hydration port in one side, and with the Caesar on the other side, you get a better control. See, once again I'm showing another video. I pierced inside, I'm aspirating. You saw the concavity which has appeared? So this is important. So the central concavity is there, and in this concavity, what happens is there's a mid-periphery bump. So when you start with your rexes, now you should know how the tear has extended in the center. First tear, what you are going to do. So you have to make sure that you practice your rexes with both right hand, left hand. In your cataract set, you should have a rexes forceps, a capsulotomy needle, as well as a 25 gauge micro rexes and micro vanas. So if you have not started eating with your left hand, you start eating with your left hand, start using your left hand, because you don't know which hand you are going to use. So in this case, my initial rexes only was large enough, so I didn't have to refashion it. Another technique to deal with them is an anterior capsulotomy. Give one shot of 1.2 millijoule of energy into the center of the anterior capsule. You saw that? One shot and the whole liquefied vortex falls down like a Niagara Falls. Everything comes down, then you shift the patient to the OT, and then the convexity is lost, the intraanterior pressure is reduced, and you can perform. You can see now, one shot I am giving, see. The whole liquefied vortex comes inside. Whenever you give one shot in the center, they are never going to extend it. This is the way the capsule will look after the AIOC capsulotomy when you are staining the anterior capsule intraoperatively. We have documented this. The AC depth does increase in these intumescent cataracts. We have published this in the Asia Pacific Journal of Ophthalmology. And we also did another comparison of different decompression technique and different rexes pattern, and we won the best physical poster in the AIC DreamCon. Coming to hypermature cataracts, how we are going to deal with these hypermature cataracts? These hypermature cataracts, most of the time you will encounter some calcified spots on the anterior capsule here and there. They will be Morgagian type. So when you are doing the rexes also, the nucleus will move here and there. You don't have enough rigidity. So this rexis marker you saw, I just put a rexis marker on the cornea, which gives me a rough guide that my rexis is going to be 5 millimeter. So you see, when I'm doing, you can see on the anterior capsular flap, some calcified spots are there. So when you're doing the rexis, you make sure that you don't go over the calcified spots. If you go over the calcified spots, then you are going to extend the rexis. Try to include or exclude the calcified spots. The first puncture, it's a Murgagnian cataract. So everything has come out, and now you see there is a nucleus, there is a bag, but there's no support anywhere else. So now when you do rexis in this type of cataract, what happens is the support of the nucleus below the capsular flap is not there. So what you can do is you can put the cohesive visco into the bag also, because that also will give you some resistance. See what I'm doing? I'm putting it inside the bag also, because that will give some resistance also, and I'm doing the rexis. Sometimes when there is no support, you can just move the nucleus towards the part where you're going to do the rexis. So the nucleus will act as a support over there. So these are the small tricks what you're going to do. See, the rexis marker is very, very important. This, another thing, I'm aspirating it, but you saw this was it looked like intumescent, but not much of fibers, material was aspirated. It was still convex only. So then start with the mini rexis. These 25 gauge micro rexis, micro vanas are very, very important. You should have them in your cataract set. They are very delicate, you have to maintain them, but they are of great help. So you can do a small rexis or you can do a snail pattern rexis, and whenever you feel that the visco is getting escaped, always put a cohesive. If your bag is getting collapsed, make sure that you inject the visco into the bag. This was a small rexis, no problem. I implanted the IOL. Always give a tangential nick and then refashion the rexis. If you are well versed with this, you start doing with the irrigation port. Why with the irrigation port is good is AC is maintained and the flap goes on moving around. So you get a better hold with the micro rexis. This is a hypermature cataract, the Murgagnian cataract. The whole nucleus is sunk to one side. So I'm giving the first puncture over the nuclear base only now, where the nucleus is there. Now this nucleus has to act like a guide or the base of the support above which I'm going to extend my rexis. So now you see, if the nucleus support was not there, then the rexis would have gone in a different direction. I have filled the bag with the cohesive visco because I want the bag to be inflated. And this is the way the rexis is managed in these patients. When you come at hard drawn, again the problems are the same. Visibility is there. So, and the pupils are mostly mid-dilated. So what I call is a judgmental rexis or AMR, that is Andajma rexis or a blind rexis. So you see these are the brown cataract. It is totally brown, you don't have any visibility. You use red glow, any glow, nothing is visible. It is only black thing what is visible to you. So staining of the capsule is very, very important. I've been always stressing this, and staining should be done properly. Always take a tuberculin syringe, take about 0.2 to 0.3 ml of the dye and air in that, and then first inject the air and then the dye. You see how hard this cataract is. Because of the good staining, this capsule is there, stained capsule is there, and we can visualize that this capsule is stained and we can visualize it. If this capsule was not stained, visibility would have been very, very difficult. See, this is in an SICS case. What happens in SICS is, you can have a large rexis. You need a large rexis in the SICS, because if you get stuck anywhere, because the large rexis, you can prolapse the nucleus into the anterior chamber. And you saw, in between, we know that the rexis is going to extend, we can rip it off or pull it towards the center. So the important pearl for managing this cataract, especially the mature intumescent cataract, is intraintegral decompression. You can do an anterior laser capsulotomy or a slow and guarded decompression of the raised intraintegral pressure. For hypermature cataract, fill the bag with cohesive so that the bag is inflated. Use CTR, needle, forceps and nucleus as the support while doing the rexis. And for hard-drawn cataracts, improve the visibility with trypan blue, or you can use a extra torchlight illumination from the tangentially from the limbus, and you can see that. And you should know how to tackle the pseudo exfoliation and the small pupil, and I would advise to do a large rexis. Thank you.